All right, everybody. Next up, we have Dr. Ingram here to talk to us about weight loss and surgery. So Dr. Ingram is a general surgeon who specializes in bariatric surgery. He completed his general surgery residency in 2017 at the University of Mississippi Medical Center in Jackson, Mississippi. And after initially working in South Mississippi, he joined St. Vincent Infirmary in 2021 and has established a bariatric surgery program here for us in the Little Rock area. This is your forward, and then this is your
All right, thank you for giving me the opportunity to speak today. We're going to talk a little bit about what's new in bariatrics. Both surgically, endoscopically, and just kind of touch on medications. I'm definitely not the expert on the medications in this room, so we'll just kind of briefly cover those. I have no disclosures, and these are kind of what we're going to go through today. So the first thing I want to talk about is kind of what are the trends in bariatric surgery. And unfortunately, to put more than just the last 10 years on there would be an even busier slide and more difficult to see, but one interesting thing is, if you kind of look, you see that the sleeve started out and has gotten more and more popular, whereas the band has kind of done the opposite. So really the change in bariatric surgery has gone from more bands starting around early to mid-2000s to really the peak at 2010, 2011, where it has started decreasing, and now sleeve is much more popular. There's a few reasons for that, and I think insurance has driven that more so than anything. I know when I started my training in 2012, there were still plenty of insurance companies that would not approve the sleeve, whereas they would approve the bypass or the band or other things. So patients would tend to veer away from the sleeve just because they couldn't afford it. As we look at some of these newer procedures that are coming out, insurance is still an obstacle. Trying to get approval for those. So what we're going to really focus on today is going to be kind of starting on that fourth line, the BPD-DS, so that's the, well actually below that. So SADI, which is a version of the BPD-DS, so the SADI is a single anastomosis duodenal-intestinal switch, essentially, which is a modification of the biliopancreatic diversion with duodenal switch. And then the next one, the OAGB, one anastomosis gastric bypass, also more commonly called the mini bypass. Okay. One thing that's kind of difficult to determine, you see this other category where it kind of fluctuates up and down, kind of teasing out what's in that other category. A lot of it, as 2015, 16 comes along, a lot of that is the mini bypass and the SADI. Just hasn't been classified as those yet. As you go back a little further, a lot of that's going to be your balloons and things like that. So it's kind of, these are the best guess numbers that we have, but, and most of this is pulled from the MBSAQIP, which is the Quality Improvement Program through the ASMBS. So that's where they get most of their numbers. As we get to these endoscopic procedures, it's based on how many of those are purchased. So the numbers aren't completely accurate, but it's the best we have. Here, I just kind of wanted to, I know the large numbers kind of get kind of confusing to follow. So again, trends with percentages. The first three lines really have, overall percentage have stayed the same, whereas bypass pretty much remained constant. Again, sleeve and band have kind of been alternate trends. So, going through, so the first things we're going to talk about are basically new techniques for old procedures. As I said, the single anastomosis duodenal-ileal bypass with sleeve gastrectomy, that's the SADI-S, and then the one anastomosis gastric bypass, OAGB, or mini gastric bypass as they're referred to. So here's a picture of the SADI. As you see, the sleeve is no different than just a sleeve gastrectomy. And an interesting thing, so not from the SADI, but the biliopancreatic diversion, that's actually where the gastric sleeve came from as a less complicated version. In the severely obese, the sleeve was initiated by, in the severely obese, the morbidity and mortality rates were extremely high, so they started doing the duodenal bypass, a two-stage step and this two-stage approach, and found that patients lost a lot of weight with just the sleeve. Talking to a lot of bariatric surgeons, this tends to be more of a revision after a sleeve for patients who have had some initial success and need some extra help afterwards. Still done as a primary procedure for many patients, but that's kind of what it has evolved into. Still kind of going back to that original description of the procedure as a two-stage operation. So this was first described in 2007, just kind of as a simplification, trying to, one, make it technically easier for the surgeon, and two, decreasing the complication rates. There's been a bit of a learning curve as far as how long the length of the different channels needs to be, how much of the initial small valve we need to bypass. But it has shown similar results to the gastric bypass. When you look at most studies, the overall excess weight loss is slightly higher than the gastric bypass. The flip side of that is the complication rates are also slightly higher than the gastric bypass. So really the trends, when you look at all of the procedures, the better the weight loss, the higher the complication rates when it comes to the procedures. Kind of moving on, so the one anastomosis gastric bypass, if you'll notice, the main difference between this and the typical Roux-en-Y gastric bypass, aside from the anastomosis you're making, is your pouch is actually a little bigger. So typically in the gastric bypass, the pouch ends right in there, about a 30 cc pouch. So here you actually do have more of a sleeve picture. The main difference in the anastomosis here and with the SADI is this is pre-pyloric, whereas the other one is post-pyloric. One of the questions that always arises with the mini bypass is, can this be done in patients with severe reflux? As we know, sleeve and of course the SADI, since it is a post-pyloric anastomosis, is relatively contraindicated in severe reflux. It increases their reflux symptoms, and if you've ever seen or taken care of a patient who is after bariatric surgery with severe reflux, they're pretty miserable and they're very difficult to deal with as far as improving their symptoms. So one of the questions is, can this be done? And based on the feedback that I've seen, it's about a 50-50. Half the people say, yeah, it works great. Other half say, no, I wouldn't do it. I would do it traditional. But again, what we're doing is we're creating a loop bypass as opposed to a Roux-en-Y gastric bypass. The thought is that we're eliminating one of the anastomoses, which again makes it technically a little bit easier and theoretically will decrease complication rates. However, as I kind of looked through, it looks like the complication rates are very similar to the Roux-en-Y gastric bypass. Now, whether that's just that there's a learning curve to this and we haven't met that number to achieve the best rates, hard to say. The Roux-en-Y has been around so long that it's a very well performed procedure, and I think that's probably some of the differences that we see, or the reason that the complication rates are very similar. But as far as weight loss, again, there was a learning curve as far as how long does the biliopancreatic limb need to be, things like that, but the early results seem to be very comparable as far as excess weight loss to the Roux-en-Y gastric bypass. And of course, that's what we compare every procedure we do to, is the gold standard, which is the Roux-en-Y gastric bypass. So kind of moving on, so these next few procedures we're going to talk about are currently not recognized as weight loss procedures by the ASMBS, which is our governing body for bariatric surgery. And therefore, they are also not going to be covered by insurance. So anyone looking for these procedures is really going to have to pay out of pocket. The only benefit to that is if your insurance doesn't cover one of the other more traditional procedures, this is going to be a little cheaper option. However, when we get to the results, doesn't seem to be worth it in my opinion. But so the gastric plication, essentially we're making a gastric sleeve by sewing it closed. So we're not removing anything, we're eliminating a staple line. As far as cost of the procedure, we're eliminating the cost of the stapler that we use, which is probably the most significant cost with the operation. And basically, you're taking a suture from the front of the wall to the side and then into the back to kind of imbricate and close in the greater curvature into the stomach. To me, this isn't a great picture because it looks like the stomach's completely closed, so I'm not sure why that's there. I think there should be a little more opening here, more like this, but smaller. But this was the best picture I could find. So this is mostly performed outside the US. However, I have seen a patient in my clinic who had a lap band with a gastric plication performed, I believe, if I remember correctly, this was performed in Texas. I don't remember where in Texas, but mostly performed outside the US. As I kind of looked through at the results of this, they were all over the place. I found one study, and all of them are case series. There are no really good retrospective, randomized, or multi-institutional studies. They're all just case series. One series I found showed 40 patients with about a 40% reoperation rate, which is terrible. And then I found another study that I think was outside the US that showed like a 0.5% reoperation rate. So there's a huge disparity in that, and I can't believe that that's all technical differences. So I don't know that I have a great opinion of this operation at the moment, but I think there's more to be learned from this. The thing I will say is the end result of the gastric plication is going to be very similar to the endoscopic sleeve gastrectomy, which is being performed quite a bit in the US. Again, kind of the same end result. You're just reaching it from a different location as opposed to going laparoscopically. We're now doing a scope and suturing the stomach tighter, really by doing the same thing. So grabbing the anterior wall, the posterior wall, and the greater curvature and bringing them all together. I will say I have done one of these. I did train on this. I did one. I wasn't a big fan. And the patient did not do well. We'll go into that in just a minute, though. So again, this really has caught on in the US and is much more popular than that initial graph would indicate. There are quite a few of these procedures being done, both by surgeons and by gastroenterologists. So this kind of expands the field a little bit and opens up gastroenterology to perform these procedures. And then, of course, the intragastric balloon. There are lots of different balloons, brands that are out there. In general, these balloons are attached to some type of catheter that is, once it's inserted into the stomach, the catheter is inflated and then pulled off. Most of these balloons are silicone-based. Again, I have done a few of these procedures, not a big fan of them. Don't think the outcomes are great, at least from my experience. But the product itself, most people have either seen or felt or held a breast implant. That is essentially what these are. Very same mold, similar size and all. And there are some that the patient actually swallows as a pill, and it looks like it's attached to a catheter, and they do it themselves. To me, that would make me extremely nervous because, one, if you're not doing it endoscopically, you don't know that it's in the stomach, and when you start to inflate it, if it's in the esophagus, you're going to have major complications. But there are pills that you can swallow that expand once they reach the stomach. Again, many different versions. Some are single, some are multiple. And one of the main issues with this is here. For the US, FDA approval is only for 6 months. And when it comes to the amount of weight loss patients can lose, the companies really advertise about 30 or 40 pounds at most. And certainly here in Arkansas, 30 or 40 pounds is not really making a dent in a lot of our patients. They need significantly more than that. The other issue is the most successful these patients can be is with a true follow-up, true program that really works on establishing different eating habits and lifestyle modifications. And as I kind of look through the studies on any of these procedures, that to me is the biggest thing that's missing. There is no true standardized follow-up, and really for any, whether you're an accredited or non-accredited center, there's no set follow-up. There's certain benchmarks that you have to meet, which is really, I think, 80% follow-up at 30 days. You need to be 50% at 6 months, which is very poor. And after that, they don't really keep up with it. For these patients to be successful, they really need lifelong management to be followed throughout. That's where I think the studies are lacking. There's not a lot of data on what is the follow-up for these patients. And I think that's where you see all over the place, where some procedures are excellent at this institution, whereas they're just okay at this other institution. So with the balloon, the main side effect is nausea. I mean, you get severe nausea that really lasts the entire time the balloon is in. You really have to be on anti-nausea, anti-spasm medications the entire time the balloon is present. If you imagine there's something floating around and your stomach wants to expel it, it knows it's not supposed to be there, so it's constantly trying to get rid of it. As you know, talking to a few patients who have had these in place, they can actually feel it moving. As they, if they jump, they can feel it rising and falling. There are times where, they feel like food is getting stuck and they sit down and kind of press on their stomach and they can push it down further and maneuver it to where food will go around it. Even though there's only about a 2% overall early removal rate, these patients are typically not real, they certainly don't enjoy food at the moment. So overall complication rates are low. The biggest thing is early removal. So we'll just kind of go over this real briefly. So currently this is the list of FDA-approved weight loss medications when they were approved. So orlistat used to decrease fat absorption, first approved in 1999. Phentermine, which is, as I see, a very common medication that patients have tried. More appetite suppression, true mechanism is technically unknown. Approved in 1959. At that point, it was only approved for 90 days, and still is only approved for 90 days. It's never been studied for longer than that. However, when you add the topiramate, this one, the combination of the two drugs is approved for longer. Then kind of the naltrexone, bupropion, appetite suppression. You see a common theme through here. Appetite suppression is the most common use. And then we get into the liraglutide and semaglutide, the GLP-1 receptor agonists, which reduces appetite, calorie intake, mostly through delayed gastric emptying. Some reports state that, especially for the liraglutide, that the delayed gastric emptying effect is most prominent through the first year, and then kind of starts to dissipate some. So just a kind of a list of the GLP-1 agonists, and I know a lot of these are being used as weight loss medications, but just a reminder that only the first two, the liraglutide and semaglutide, are actually FDA approved. So what do they do? It's derived from a gut-derived peptide hormone, exhibits glucose-lowering effect by stimulating insulin secretion from pancreatic islet cells, and again, kind of slows gastric emptying and helps with intake issues. One of the key things, at least in my area, is what do these do for patients who are undergoing surgery? And The anesthesiology groups just released their recommendations that these need to be stopped about 3 weeks before any type of elective surgery. So it's a significant, anything less than that, they need to do rapid sequence for risk of aspiration. So there's definitely a significant effect. I've seen a few reports recently that showed that even patients who are off for longer than that can still have full stomachs on EGD, have had some aspiration events undergoing elective surgery. So certainly anything emergent is also a problem on these medications. Just again, that's more my field, but I've seen quite a bit of that. So.
I have a question.
Yes.
Can you comment on, I see more and more, I mean, obviously, based on the numbers, I'm in Northwest Arkansas, and I feel like I don't see quite as many sleeves as your numbers would suggest, but I feel like when I see them in my clinic, they're just not that successful. And so can you just comment on like reoperation or is there options after that for surgical management for the sleeve patients?
Yeah, so with the sleeve, that's the main operation, that there is a second operation that you can perform. And that's where the SADE has really been more popular. From my personal belief, patients who initially do well with the sleeve but need additional weight loss would be a great candidate for the SADE down the road. Someone who has a sleeve and has very little success or no success is probably more of a lifestyle management, probably more of a lack of change of lifestyle, and therefore doing additional surgery is not necessarily going to help. Now, there's always that belief that when you do the bypass, the internal mechanism of compliance with the dumping syndrome, if you eat high carb or high sugar meals, that's going to make you feel terrible, to try to prevent those habits. I see some argument to that, but I also see patients who just go through it anyway. But yes, so for the gastric sleeve, you can do revisions through that. Really with the gastric bypass, there's not, unless you're making a longer biliary channel, there's not much you can do to revise those.
So usually, how do you decide the patient will come and do the, kind of run one bypass or just a sleeve?
So it's oftentimes patient preference. I can't tell you how many times I've had patients come in and they're like, I don't want a bypass. I know somebody who did X and had whatever complication. Really when it comes to the relative contraindication of reflux with the sleeve is the main deterrent from doing a gastric sleeve. I've done plenty of patients with severe BMI in the 60s with a sleeve who do well. Again, there's a limit to what to expect from that, but treating that as a more of a two-stage operation where you have the sleeve, let's see how successful you can be. If you're extremely successful, you may not need anything further. If you're extremely successful and then you gain some weight back, then you have another operation that you can perform to help them get to what their goal is. Whereas, again, with the bypass, you don't have anything else you can do. The other part of that is the sleeve, when it comes to complication rates, is essentially half of any of the other operations. So technically, it's a much easier operation to perform. The tolerance from the patient is much better, again, assuming they don't have severe reflux. And the biggest component to their success is going to be their lifestyle change. So, I tell patients all the time that I can take out all of your stomach and you not lose any weight. So, the biggest thing they can do is change their lifestyle. And if they're not willing to do that, it doesn't matter what I do.
You make a really important point. The best centers in the world are Sweden, Italy, and the Cleveland Clinic. And they have great surgeons, I'm sure. But what they have is they have follow-up. And then the Swedish obesity study done maybe 10 years ago, and people that were treated medically, 50% of them still had diabetes and hypertension. People that were treated with surgery, maybe 10% had. And the reason was because they had support groups that followed them all throughout.
Right.
And the Cleveland Clinic has a similar thing. And there's an Italian surgeon, his name is Magazzini, who also has 2-year, especially if you've not had to take any medicine for diabetes for 2 years, that's basically a cure.
Yeah.
But the bottom line is our healthcare system is deficient, and for you to do the surgery and then to go over diet is a yeoman's burden to do, and I think that is a real deficiency, particularly with the fact we get no help from the food industry whatsoever. So I think your point is absolutely well taken.
Absolutely. And there's a lot of research going into, medications to decrease complication rates, and then post bariatric surgery to improve the results. So there's research going into that right now, and there's some preliminary data out, but I think there's more to be done.
2 questions. First, very short. What is kind of the standard upper age for the patient?
So my limit is 75. Different programs are going to set different age. Most are between 70 to 75 for an upper limit.
Second, for the long-term malnutrition of vitamins and micronutrients, what is your program recommended for sleeve and whatever else might be appropriate for dealing with that?
So for sleeve, their absorption is no different. So once if they're severely deficient, you're probably going to have to replace through IV replacement initially. But once you get them to a regular range, then you should be able to maintain that with oral multivitamin. Now, there is, when you look at the recommendations from the ASMBS, the daily vitamin level is slightly higher than what you get in the over-the-counter multivitamin. There are several different brands of bariatric strength vitamins, and for the most part, they cover all of the minimum recommendations except for the B vitamin. So a bariatric multivitamin plus a B vitamin complex is the recommendation.
Are you in favor of the patches that a lot of patients talk about?
I've seen 1 or 2 patients that wear the patches. I don't have a lot of experience with that, so I wish I could comment more, but
Do you see a lot of hypoglycemia post-op after weight loss surgeries?
it's funny you bring that up. So she's not in here, but I know she wouldn't mind. Bonnie is one of my patients, and she's given me permission to say this in front of you. So she actually has hypoglycemia after a sleeve. That is, I believe she started Ozempic for that, which has improved that, which, don't ask me to explain that.
By the way, I look at the doctor, so.
That's pretty honest. That's pretty honest.
Yeah.
And do you actually see, before that recommendation on GLPs and stopping them, because it's this whole hullabaloo, right? Like, oh my gosh, then we have to retitrate. Were you seeing people with stomachs that are full and problems related to that?
So yes. Me personally, I have not. Going into bariatrics, we have them stop those in advance anyway. I have not run into that issue, but talking to a few of our anesthesia colleagues, yes, they have seen, and they have already been treating them as rapid sequence just to eliminate that problem.
What does that mean? I'm sorry.
So basically treating them as if they have a full stomach. So
Okay.
not doing
Okay.
compression, cricoid compression to prevent aspiration,
Okay.
where they give them medication and they are basically out immediately so that they can report.
Thank you.